Hello, welcome to Behavioral Health 101, Introduction to Behavioral Services. Today's presentation will be on adolescent services. So, when we think of adolescence, we have to realize that this is a relatively new stage of development. This stage usually encompasses the teen years, which run approximately from 12 to 19. The research on this stage is rather new, as there was little acknowledgement or understanding of adolescence as a separate stage of development until the later part of the 19th century, keeping in mind that for the vast majority of human history, that when a young person, 13, 14, hit that age, they were part of the adult environment. They worked, they participated in child raising, they would often marry at 15 or 16, they would become apprentices. So in terms of adolescence that we understand now, this did not exist prior to the 1800s. G. Stanley Hall began his study of adolescence in 1882, culminating in his groundbreaking book on adolescence published in 1904. Hall described adolescence as possessing a lack of emotional steadiness, violent impulses, unreasonable conduct, lack of enthusiasm, and lack of sympathy. Urbanization of the past 200 years has had an impact on individual and family lives, including the lives of adolescents. Although adolescents in the past acted in ways that are strikingly similar to the ways in which they act today, the many profound changes within U.S. society, including changes in family structure, the public educational system, and expectations of adolescents within these systems, have influenced the ways in which contemporary adolescents both develop and behave. Development occurs within various domains, including the intellectual, emotional, psychosocial, moral, and even spiritual spheres. It is likely that what was considered normal behavior for adolescents in 1900 would not necessarily be normal in contemporary society. In other words, it is important to consider the normative aspects of adolescent development within a historical context. So when we think about what would be considered normal in 1900, we cannot compare that to what's considered normal in today's day and time. What is expected of an adolescent and what is considered adaptive and healthy behavior depends on what is occurring in the world during the time in which the adolescent lives. Another developmental aspect is culture. What is considered normative and emotionally healthy within one culture may be considered maladaptive in another, and what is considered respectful and honorable behavior in one culture may be a sign of emotional disorder in another. Research on development within a regional context conducted in 2001 found that rural adolescents felt less pressure to become involved in gang activities, were confronted with less violence both on and off campus, and felt less academic pressure both from their school and their parents compared with adolescents residing in urban areas. So, developmental context is the key to understanding adolescence. Keeping historical, cultural, and regional context in mind will assist the human service and behavioral health practitioners in not mischaracterizing certain behaviors because their origin is either misunderstood or not valued by the majority culture. Most of the developmental theorists agree that adolescence is a time of searching for one's own identity and developing a sense of autonomy. Autonomy is, in other words, independence. So let's move on to Jean Piaget. And he is a Swiss-born biologist who was very active in mid-20th century. He became a psychologist and developed a theory of cognitive development that is still the dominant theory of intellectual development today. So if any of you are ever interested in becoming a teacher, Piaget is one of the leading theorists that you will read about. Piaget believed that as children approached adolescence, they begin to develop the ability for logical reasoning involved in abstract thought or reasoning. This enables us to have empathy by putting ourselves in someone else's shoes. It allows us to think metaphorically, to understand sarcasm, to deduce, to analyze, to synthesize, and to rationalize. So instead of just seeing things as they are in a concrete way, we now understand metaphor. We understand what lies beneath a word or a joke, and we're able to get the inside or the dirty aspect of a joke. It also allows us to understand and thus internalize moral standards, to not just know that something is wrong, but to understand why it is wrong. Abstract reasoning is useful and a powerful intellectual tool and can be a lethal weapon in the hands of an unstable and angry adolescent. The necessary skill of logical or abstract reasoning often enables a troubled adolescent to rationalize reasons to rebel. So you may have a teenager who has everything they could ever ask for. They have nice clothes, they have all the technology, toys they could ever ask for, they have a car, they ask, you give, and yet they still find reasons to rebel. It is part of the nature of a teenager to rebel. Adolescent rebellion can include any behavior on the part of an adolescent that is in marked opposition to standard rules, either within the family or within society in general. Determining what specifically constitutes rebellious behavior, though, can be a bit more challenging and often depends on current social mores, as well as one's own personal value system, otherwise known as our context. In general, any behavior in adolescence should be considered maladaptive if it is interfering with normal functioning and causing problems in the adolescent's everyday life. When we think of behaviors, we want to talk about external behaviors first, and we're going to talk about conduct disorders. Conduct disorder and oppositional defiant disorder, which we'll discuss next, are disorders included in the Diagnostic and Statistical Manual of Mental Disorders that are diagnosed during adolescence to describe behavioral problems in children and adolescents. Conduct disorder, the more serious of these two disorders, involves a consistent pattern of behaviors in which social mores and rules are habitually broken and the rights of others are consistently violated without regard for the other person's feelings. Again, what most often determines the difference between the adolescents who are harmlessly spreading their wings and adolescents with conduct disorder is the frequency, persistence, and seriousness of the maladaptive behaviors. The next external behavior is oppositional defiance disorder, which is characterized by a milder set of behavioral problems, including negative, hostile, and defiant behavior, such as losing one's temper, arguing with adults, and consistently refusing to obey rules. Other criteria include blaming others for personal mistakes, being easily annoyed, frequent feelings of anger and resentment, spite, and vindictiveness. We're going to move on to internal behaviors. Adolescents, like children and adults, do not always manifest their emotional problems in external ways. Some of the most emotionally disturbed adolescents turn their anxiety, anger, and sadness inward with behaviors, emotional disturbances, turned inward can often be the most serious of all, putting these adolescents at higher risk of depression, self-abuse, and suicide. The term comorbidity is used to indicate the existence of two emotional disorders simultaneously, and the comorbidity of depression and anxiety is quite high, with approximately 80% of those with depression also suffering from anxiety. Treatments for depression and anxiety can include counseling to drug therapy, which includes antidepressants and anti-anxiety medications. Adolescents suffering from depression and anxiety often display many self-destructive behaviors, the most serious being suicide, because adolescents can be impulsive, dramatic, and narcissistic. Deliberate self-harm, or DSH, is deliberate, repetitive attempts to harm one's bodily tissue without a conscious desire to commit suicide. Hicks and Hink use a more narrow definition, which they define as the intentional act of tissue destruction with the purpose of shifting overwhelming emotional pain to a more acceptable physical pain. Adolescents are at an increased risk for self-injury, with 39% of the adolescent population admitting to having self-injured at some point in their lives, and 61% of adolescents in a psychiatric inpatient setting having self-injured. Approximately 44% of college students have admitted to engaging in self-injury. Studies indicate that of all those who self-abuse, 97% are women. This may be due at least in part to how females are socialized to internalize their negative feelings, whereas males are socialized to externalize their negative feelings. So guys are more likely to get into a fight or get into a screaming match, whereas girls are more likely to internalize their feelings. 50 to 60% of cutters were sexually abused as children. Issues such as impulse control and emotional regulation are paramount in any successful treatment plan, as is assisting the adolescent client in learning how to understand and effectively manage intense or uncomfortable emotions in a direct manner. Adolescents are at a particularly high risk of suicide ideation for several reasons, including their propensity for impulsivity, as well as their frequent feelings of omnipotence. Between 1999 and 2006, the most recent data available, 11% of all deaths of adolescents between the ages of 12 and 19 were caused by suicide, making suicide the third leading cause of death for this age group. Adolescent suicidal behavior can include suicidal gestures, suicide attempts, and suicide completions. It is important to distinguish between each of these types of suicidal behavior for the purpose of intervention. So somebody who talks about suicide versus somebody who attempts suicide, those are two very different issues. Adolescents who are plagued by feelings of hopelessness have little to no social support, have feelings of hostility, and have a negative self-concept or at the greatest risk for committing suicide. Other risk factors for suicide include having a friend commit suicide, and for males having a gun available was a significant risk factor, and for girls having low self-esteem. The single most powerful predictors of continued suicidal behavior are the existence of depression and family dysfunction. So how are we managing interventions for suicide? Current treatment interventions focus on school-based suicide prevention education programs, crisis centers, including teen suicide hotlines, screening programs aimed at identifying high-risk adolescents. It is important to note that 60% of adolescents who committed suicide also had a history of involvement with the criminal justice system. So that is an area that is really untapped in terms of intervention programs that can help reduce the number of suicides. Another issue that one sees, particularly amongst adolescents, are eating disorders. And this includes anorexia nervosa and bulimia nervosa. Females are 85 to 90% of all documented cases of eating disorders. However, the number of cases in males is increasing. Men who have eating disorders tend to overeat, whereas women tend to undereat. Anorexia involves the intentional starving of oneself and the refusal to maintain expected body weight. The DSM-5 criteria for anorexia includes theories of the causes of anorexia, including maladaptive family patterns where the adolescent's anorexia is presumed to help protect unhealthy family dynamics by focusing the attention away from other dysfunctions. Family counseling is the most common recommended inpatient treatment for adolescents who are at risk of serious health complications from anorexia. Bulimia involves a pattern of binge eating followed by purging, the use of laxatives, vomiting, and excessive exercise. Bulimia is far more prevalent than anorexia. The common risk factors of adolescents suffering from bulimia include perfectionism, body dissatisfaction, and low self-esteem. Treatment for bulimia often includes insight therapy, family therapy, and cognitive behavioral therapy. Depression and anxiety are often associated with both anorexia and bulimia. Other issues that affect the adolescent population include attention deficit issues like ADD or ADHD, sexual behaviors, teen pregnancy, and drug use. So, how do we manage adolescence? Well, the services that are available are varied. Practice professionals who provide adolescents with clinical services include psychiatrists, marriage and family therapists, licensed clinical professional counselors, and licensed clinical social workers. Adolescent services are available in settings such as in schools by school social workers, counselors, and psychologists. Residential care is a practice setting often utilized for adolescents who are severely behaviorally disordered and at a high risk of self-harm and destructive behaviors. Placement times can also vary, with some adolescents being placed in a residential facility for a few months to some who require several years. Group homes or therapeutic foster homes offer less structured residential care. Treatment modalities in these facilities often include a combination of behavior modification, where desirable behaviors are rewarded and undesirable behaviors are punished. Other treatment modalities include individual therapy, group therapy, and family therapy. The most structured and most serious of all residential treatment programs include correctional institutions for adolescents, which focus on corrections and punishment compared to a therapeutic environment. Another type of treatment facility is an inpatient psychiatric hospital. The environment focuses on stabilizing the adolescent's high-risk behaviors, such as suicidal behavior or self-abuse. Many of the same type of therapies are available as an inpatient setting as in a residential treatment center, with the exception that drug therapies may be more prevalent in a psychiatric hospital. Behavioral health professionals must be aware of the way in which race and ethnicity affect adolescent development and behavior, as well as any negative stereotypes that might affect the types of diagnoses adolescents receive. A 2001 study found that African American adolescents were more commonly diagnosed with conduct disorders, whereas Caucasian adolescents were more often received a diagnosis of depression. This is attributable to variables such as misdiagnosing based on cultural differences and misperceptions. Latino adolescents, specifically Mexican Americans, are at a higher risk for delinquency, depression, and suicide compared to Caucasians. A 2011 study revealed that African American, Latino, and Asian adolescents with major depression were significantly less likely to receive mental health treatment, including prescription medication, compared to non-Hispanic white adolescents, regardless of income levels and health insurance. Social conditions such as poverty, high crime neighborhoods, and unemployment contribute to a significant portion of mental health problems in racially ethnic youth. When behavioral health professionals are trained to deliver culturally competent counseling, they can help families ensure that as many adolescents as possible move through effective programs and supportive services at all levels. These adolescents, who often seem destined for a lifetime of narcissistic obsession, most often evolve into loving, caring, and responsible adults. That will finish today's presentation. If you have any questions, please feel free to email or text me or leave a comment. And I hope you have a fabulous day. Thank you very much for watching.